for this region, knee joint replacement is not a good answer. And because of the financial strain of knee replacement, this is also not a good choice for the country like ours. Though we are progressing, but the lifestyle cannot be changed. As we have always discussed, there are three domains of learning, and they are knowledge and attitude. The purpose of these webinars is to equip you all with knowledge and which will help you change your attitude so that you believe that knee preservation is an option and which should be very seriously tried. And having done that, we'll provide you with the skills in the pre-conference workshop on 13th December at Lucknow, and for which all of you should register. As we are aware, the objectives of the treatment is to conserve the knee joint for life. And this must include the lifestyle modification, weight control and exercise, which is successful in majority of the patients and especially in all cases in early part of the disease. The success story of HTO we had discussed, and we must remember that knee replacement is internal amputation of the knee. And we must remember that the industry is trying to push UK is an alternative to osteotomy, which is not. And the other thing is HTO is never synonymous with open or closed wedge. It must be specified what the plan is or what has been done. The objectives of today's webinar are, I'll be discussing on pre-operative planning, and then we have closed wedge osteotomy, which is Supratubercular by Dr. K S Maheshwari, and closed wedge Infratuberosity by Dr. Dinesh Thakkar. Dr. Maheshwari is the Chief Orthopedic Surgeon at Maheshwari Orthopedic Hospital in Jamnagar, Gujarat. He has a vast experience of more than 40 years of conserving knee. He has been the past president of Gujarat Orthopedic Association. He has a patent holder as Maheshwari Jig, and he has done fellowships in many countries all over the world. Then we have Dr. Dinesh Thakkar, who is our Joint Secretary and member of the IOA Knee Preservation Committee. And this is me as your chairperson. I have the distinction of doing a knee conservation fellowship at Lausanne, Switzerland, to learn the art of open wedge high tubule osteotomy. For panel discussion, we have Dr. Mangal Parihar, who is also advisor of IOA Knee Preservation Subcommittee, and his special interest is external fixation, control of infection, complex fractures. But from the point of view of osteotomy, he has a huge experience of osteotomy as a solution for OA knee. Then we have other panelist, Dr. Ajit Saigal. He is member of IOA Knee Preservation Subcommittee. He is presently the Secretary General of SARC Orthopedic Association, and he's been the Vice President of IOA. Now I'll request Dr. Chadha for his word of wisdom as the incoming president.
Thank you very much, Dr. Sanjai Rastogi ji. On behalf of the Indian Orthopedic Association and on behalf of my dear colleague, President of the IOA, Dr. Atul Srivastava, I welcome you all for this very important knee preservation meeting today. It's a pleasure to be in the company of legends who have actually conserved the knee over past 4 decades plus, Dr. K S Maheshwari being one of them. So it's a pleasure to have Dr. Maheshwari and Dr. Dinesh Thakkar, both of whom belong to 2 different generations, but do things above and below the tibial tubercle, but try to salvage the knee and keep it the way the Lord Almighty gave it to us, without replacing or doing an internal amputation, as mentioned by Dr. Sanjai Rastogi. We also have experts in this field, Dr. Mangal Parihar from Mumbai and Dr. Ajit Saigal, both of whom have immense experience and have used these tools to sort of not just improve on their knowledge, skill, and attitude, but also to actually polish their technique and would share their inputs as far as the finer nuances of knee preservation surgery is concerned. I welcome you all for your deliberations today. We also have with us our Vice President, Dr. Anup Agrawal, and I would request him to say a few words before we hand it over to the academics and take it forward.
Dr. Anup Agrawal.
Sorry, sir, I'm driving. I was little problem in the network. So thank you, Dr. Sanjai Rastogi, sir, Dr. Ram Chadha, sir. It's we have these speakers today, Dr. Mangal Parihar, Dr. Maheshwari here to talking about knee preservations. And I'll not come in between the delegates and the educators. So let's start the webinar right away. Thank you, sir.
Thank you very much for your word of advice. So we proceed with the first part, which is how to plan for a knee conservation, having decided that this patient would benefit from knee preservation. And the most important thing is that we have to have a full length X-ray, which is taken from hip to ankle and the patella facing front. And when we see this diagram, the patella is seen in the center. So this is the essential part of the preoperative planning. Then we draw the mechanical axis to find out whether it is normal or deviated. And for this, we mark the center of the hip. Then we mark the two convex points on the femoral condyle, join them to mark the distal femoral joint line. Then we draw two perpendiculars at the end of the condyle to this and mark the center of the condyle. Similarly, we mark the two concave points at the tibial plateau at the subchondral line, join them, draw two perpendicular line to it at the ends of the condyle, mark the center, and similarly, we mark the center of the ankle joint by dividing the distal femoral condyle, the distal tibial condyle by talus. And then we connect these two points, center of the hip to the center of the ankle. And if this line is passing medial, 15 millimeter medial to the center of the tibia, that means this patient has varus and it will require correction. But then we have to decide where the deformity is, and then we draw the femoral axis and the tibial axis and measure the mechanical lateral distal femoral angle. And if it is up between 85 to 90, then it's normal, as shown in this case. But on the tibia side, the medial proximal tibial angle is 78. That means this is the cause of deformity, and we'll have to do a osteotomy at this. As we discussed, this can be done by two methods, either a medial open wedge or a lateral closed wedge. And to decide further, we mark the Fujisawa point, which is the place from where the weight-bearing line should pass in the patients who have nearly lost their cartilage. And usually this is the condition when patients approach us. We draw a line from the center of the hip to the Fujisawa point and extend it. This is the future weight-bearing line. And after that, we define the hinge joint. For an open wedge, this is just proximal to the tip of the fibula. And we draw this line from the hinge point to the center of the ankle. and then we rotate this line onto the futuristic joint line and measure the angle alpha. Now this angle is transferred onto the hinge joint, and this defines the amount of wedge which has to be opened, and h is the height of the wedge. This shows the BC is the opening, and this is the alpha angle. But when we have to do a close wedge high TV osteotomy, the way we'll be doing it today, we draw the line which is the futuristic joint line which we want after the osteotomy. Then we mark the hinge point which is on the medial side, because we are going to do a close wedge osteotomy. And then we rotate a line from the joint line, from the hinge joint to the center of the ankle, and this is the alpha angle. This angle is transferred onto the lateral side, and once we take out this wedge, we close this and the alignment is corrected. Now this wedge could be removed above the tuberosity, like Dr. Maheshwari will tell us, or below the tuberosity, like we'll be having discussion on this from Dr. Thakkar. So now I request Dr. Maheshwari to give a talk on lateral close wedge osteotomy, which is above the tuberosity.
Thank you, Dr. Rastogi, for giving me introduction and giving me this opportunity to share my views on close wedge osteotomy, supratuberosity. At the outset, I am thankful to Indian Orthopedic Association for giving me this opportunity. Dr. Chadha, Dr. Agrawal, and our panelist, Dr. Mangal Parihar, in the midst of these senior people. I'll be proceeding for my talk. High table osteotomy is a subject which has been now popularized and which has been now discussed in orthopedic surgery and all the conferences. There are multiple ways of doing high table osteotomy: open wedge, close wedge, with the different implants. High table osteotomy with close wedge is not that discussed, but today the subject has been focused on the lateral close wedge, and I'm going to share my views on that. In fact, when I was a resident, I observed this technique many a times with my senior professor, Dr. V.M. Shah. And thereafter, I got opportunity, after I passed my MS Ortho, I got opportunity to work with Dr. K.T. Tolakia in a fellowship program. And I have seen them that sir were operating upon the patient with the commentary technique. And Dr. Junjunwala, and also I have observed the Dr. Sancheti, they were fixing with tension band wires. One thing common I observed was that this technique was giving very good result in the patient, and that was the fascination which ultimately took me to go with this technique in my practice. My commentary has started in 60s and 80s, as we know about. I'm just giving you a brief because it is little known about the lateral close wedge. So I'll spend 2 minutes for that, and then straight I'll go with the technique. Thereafter, it was not in the limelight because after the knee replacement, the total knee introduction, this procedure has gone into abeyance, and because of the poor technology available at that time, the wedge was either under or over, and the longevity was hampered, and that's why this procedure was in abeyance. But then Professor Kosino from Japan has popularized, and he has proved that cartilage can be regenerated subject to it is being given proper environment. Now, why this happens? That mainly in varus it happens. The arthritis starts in the varus only. It's very common. The real picture is because of the normal physiology. In normal physiology, 70% of the total weight goes on the medial compartment. Now, mild deviation of 6 degrees can increase it to 97% on the medial compartment, and 4 degrees of valgus can reduce to 50%. So, if there is mild deviation in the inherent, we have got 4 degrees of varus right from by physiology, and little bit more varus can lead ultimately to the medial compartment arthritis and the varus deformity. These are the different stages of varus and arthritis. The mechanical axis is passing medially, but gradually as the varus increases, the arthritis also increases and can lead to the more and more varus on the middle side. Ultimately, patient succumbs to knee replacement because of the severe pain. These type of patients should be intervened in between when they are in the stage of the line which is 2, 3, and 4, where they should be intervened, and we can save the knee, and we can in the real sense we can say it is knee preservation surgery. We are talking about the correction of the varus mainly, so we must know what are the components of the varus. The varus can be from the femoral condyle, it can be from tibial condyle, can be because of the erosion, the varus can happen, and also because of the lateral laxity of the ligaments, the varus can happen. We have to identify this. If we identify this, then we'll be able to give proper line of treatment, and we can suggest the proper line of treatment to the patient. So preoperative planning, as Dr. Sanjai Rastogi has given us very nice description on how to measure the angles, and he also has suggested the angle alpha. In our country, we have seen the patients are of very short stature. Particularly, this is more common in the female, and they are of very short stature. And because of that, the bone size is so small that sometimes we feel, at least I personally feel, how I'll be able to remove the wedge of 2 centimeter or the correction of the 20 degree. But the smaller the bone, the wedge may be small. That is what we see here is a D. And the bigger the bone, the wedge may be H, but the angle alpha doesn't change. So correction can be achieved. These are the examples how we do measurement in my practice. And as we see here, the same thing has been described by Dr. Sanjai Rastogi. And this is what the procedure of measurement. I use the software Bone Ninja, and I'm very happy using that software. And it gives me perfect preparation before I proceed for the surgery. Here we see the patient where the correction has been done. The line is passing through Fujisawa, and the correction is done nicely. And we can see the right leg is now clinically looks straight and in alignment. There are 4 steps of the surgery. The first step is the fibular head excision. The second stage is wedge preparation. Third is closing of the wedge, and the fourth is fixation of the implant. Previously, we were fixing this osteotomy with the staples, but now we have replaced, since last 2 years, we have replaced with the plates. Initially, when I was doing with the staple, I was giving plaster along with, but now with the plate, the plaster has been eliminated. The instruments required, these are the common instruments we need. And the main thing which is necessary to be understood is about the thickness of the saw blade. It should not be more than 0.0 mm. Thinner the blade, the bone loss will be accordingly less, and we can save more bone. And the osteotomy also should be of 0.8 to 1 millimeter thickness, and it should be 2 to 2 centimeter width. And with these basic instruments, we have now recently started using radiolucent retractors and spikes, and they are of immense help during surgery because it doesn't hamper view while using the image intensifier. The surgical technique, supine position, with antibiotic prophylaxis under tourniquet with image intensifier on the contralateral side. This is the basic setup we start with. Before we proceed, we confirm the laxity, FFD, as well as the alignment of the limb. And then with the lazy C incision, which starts from the lateral joint line, just below the tubercle, we make around 7 centimeter long incision. And with this small incision, it gives us good exposure. And because it is small, the wound problems are also minimum. After the skin cut, immediately we see the fascia of the tibialis anterior muscle on the lateral side. We cut the fascia and then we open up the proximal tibia lateral side. And we open up the bone, we clear the bone. And once we go deeper, we reach to the fibular head. We clear the fibular head. As we see here, the fibular head is here. And this is the fibular head. We clear it, and with the help of the knife, we separate the fibular head from the proximal tibia, and the joint is cut. Then the stage comes is of the osteotomy of the fibular head. The important structure we come across at the fibular head is the lateral popliteal nerve. And lateral peroneal nerve, this peroneal nerve is to be protected because it is passing through posterolateral side of the posterior part of the fibular head. If we chop off the fibular head medially 1/3, we will never come across this nerve unless it is anatomically having mal placement. While putting the osteotome, we should put it at the 45-degree angle so that our tip will never go vertical straight down to the nerve, but it will always go medially when there is no positioning of the nerve, and we deepen the osteotome and then we remove the fibular head. Now proximal tibio-fibular joint is clear. So now the second stage thereafter is the clearance of the proximal tibia anteriorly and posteriorly. Proximal third of the tibia just above the tubercle, we clear the bone by cutting the retinacula anteriorly. Once we cut the retinacula laterally from the superior border of the lateral border of the proximal tibia, then straight we can feel that there is a void, and this void is between the retinacula and proximal tibia. There may be septas which we can bluntly with a blunt hand, with a blunt finger pushing, we can clear out the proximal tibia. If not, we can use the scissor or knife to cut the septas, and we clear the bone from tibial tubercle up to the joint line anteriorly. So the bone is now open anteriorly, and thereafter the next step comes is the clearance of the proximal tibia from the posterior side, the proximal tibia from posterior side. While doing it, we keep the knee in flexion. As we know that the important structures are passing through the posterior side of the knee, and to protect them, once we flex the knee, all the important structure will fall down, and then from below upward with a periosteum blunt dissection, we start clearing the tibia proximally. The periosteum from the tibia is cleared up to the level on the medial side completely from lateral to medial, and then gradually we proceed upward and we reach up to the joint line, and we clear total posterior side of the periosteum. So anteriorly and posteriorly, the periosteum is totally clear. And now the stage comes that we prepare for the osteotomy. We use 2 K-wires. The first K-wire we pass just 2 centimeters below the joint line, and it just pierces the lateral cortex, the medial cortex. And the second wire we fix. Before that, we measure the wedge what we want to remove. This is how we place the ruler and we measure the length. Here it is 2 centimeters with around 20 millimeter of the correction we want. And we see here that the tendon insertion is just here. The tendon insertion is just here, and the osteotomy will be passing through this plane. So it will, and we definitely we are very careful while doing this osteotomy that we will not damage the nerve, damage the tendon. Then we push the second wire and it will be meeting the first wire medially and it will touch there. So this is the wedge we are supposed to remove. This is the angle alpha created on the bone under image intensifier. And then we start cutting the bone. First, we cut the proximal. With the saw, we cut the lateral surface, but we never use this saw on the posterior side. Because the anteriorly it is under vision, so we can use with the saw. There is hardly any problem. But we reach up to medial side and we leave last 2 centimeters with the saw. But we never use this saw again. I say before on the posterior side. Similarly, we use for the distal cut. Again, we use for the anterior side up to medial. We leave it up to 2 centimeters. Once we have cut the anterior surfaces on proximal and distal with the saw, then we use our osteotome for rest of the cut. And once the osteotome is done on the complete osteotome is done on both the sides, then we push 2 osteotomes superiorly and inferiorly simultaneously one by one, and we can see the wedge is delivered and it comes out in toto. Usually we get like this. Sometimes even it is, sometimes may not. But then we remove with the nibbler. Once we remove the wedge, we don't throw it. We make small wafers like this, the small chips, and we compress and make them like a wafer. And then we put back into the osteotomy site here, and we one by one we put inside. And as we see here in the image intensifier, the bone graft, it acts like a bone graft. We push it in, and then we close the wedge. After that, we fix the osteotomy with the implant, either staple or plate. And as we see here in the inset, the staple has been fixed, and hardly we see there is any gap, and the correction has been achieved. Now we have started using this lateral closing plate, and it is a locking plate, variable angle, and it stabilizes the osteotomy nicely, and we don't give plaster in such cases. The wound is closed in layers, and we always use drain. And for the plate fixation, we give a gentle, soft compression bandage. This plate is newly introduced. It is available in variable angles of corrections. It is first of its kind for anatomical fitment as per correction angle in lateral closed wedge osteotomy. It has developed by my son, Dr. Shalin, and now we have applied for the patent. The post-op protocol: first 15 days, long knee brace, active knee bending exercise, foot and ankle exercises, and non-weight-bearing crutch walk. Patient can start non-weight-bearing crutch walk on the next day. And after 50 days, full knee bending exercises and partial weight bearing is permitted. And after a month, we allow the patient to put full weight bearing and can resume the duty. So this is what is our post-op protocol. And as we see here, these are the correction achieved, and angles up and the slope has been maintained nicely. The complications, there are a list of complications which can happen, but in our cases, what we have observed was the delayed union and non-union in certain cases. Reported, it is 1 to 3%. In distal tubercle, 14% of non-union is literature says, and in proximal tubercle, it is 3%. In our case, we have observed in 2 patients, and this is one of them, where we see the gap is persistent and it was not filling up. After 3.5 months, we have changed it and we have fixed it with the plate and bone graft, and it has united nicely after 4.5 months, and patient was up and out. The delayed union we have observed in the smoker, diabetic, and arteriopathy and alcohol type of patients, and where This is the patient after 3 months. We see the gap is medially filled up, posteriorly filled up, but anteriorly still not. And we waited and given dietary supplements and allowed them to put partial weight very continuously, and it has united after 5 months. Loosening of implant was observed in multiple patients, and we have removed these staples after. Here it is united, so staple was removed and patient was up and out again. Peroneal nerve palsy, we have not observed it in any patients because we do this procedure carefully in all patients, and in our big series, we have not seen any nerve palsy in any patients. Few case examples: 90 kg weight, 59 years housewife with diabetes mellitus with severe varus deformity, was suggested replacement, and we have done correction with osteotomy and staple fixation. At that time, we have given plaster, and after 10.5 years, the patient is doing wonderful exercises and able to sit and able to climb the steps. And after 10.5 years, she has climbed Mount Chotila twice. As per her history, she was able to do that. Another lady, she was having osteochondral defect and was having severe pain on the knee joint. She was not able to walk even a single step, and was suggested knee replacement again. And we can see here the osteochondral defect and the painful gait she was having. And with this, she has come to us, and because the lateral compartment was good, so we have not done any other procedure, but we have opted and we have suggested ITV osteotomy. It is being done, and as we see here, the osteolytic lesion is persistent, and this is after 4.5 years picture in the follow-up, and this is the clinical picture of the patient. She was mobile immediately after the surgery. She is able to climb the stairs. She is able to sit and squat. That is what is our main requirement in the village patients. Another lady having bilateral knee pain with ischemic heart disease. She was operated. She was having pain in both the knee joints. She was operated on one side before 13 years and on the opposite side after 12 years. This is 13 years before. One side, then again she was having pain. She came for another side. We again operate on that side. But meanwhile, one observation which I wanted to highlight here was the cartilage here. As we see, it has become very smooth, and it gives us that the cartilage is regenerating here. This is after 13 years. She is able to do her routine activity very comfortably. 80 years old housewife was having knee pain, which she came to us for the correction, was suggested again replacement. We have done HTO, and on the left side, this is she's sitting on the left side. This side is operated, and she is able to manage her routine activity without any issue. Some examples of the plate: 48 years old housewife with severe varus, corrected, and this is the exercise pictures, and this is the clinical picture. She was hardly able to walk before, and now she is able to do her routine activity comfortably. Another patient, severe knee varus and with grossly restricted knee movements. She was again operated for the same, and we see here the pre and post gait of the patient. So this is what was the result of this technique. 59 years severe knee varus deformity. She was operated for knee replacement before 5 years, and for the knee pain she came to us for the knee replacement only. Previously also we have operated, but this time we have opted for knee preservation because the lateral joint line was clear, and thereafter the procedure was done. Now this is her gait before and after the surgery. Another 52 years old male, severe bilateral knee varus with hypertension and diabetes. We have operated on both the sides. These are the X-rays and scanograms, and this is the clinical picture of correction, and this is the pre and post gait of the patient. Another patient operated for the same varus deformity correction. So these are the results of this surgery, and these are the patients who are operated in the hospital. There's a few patients who are operated here in this hospital up till now, and out of that, one patient was of 120 kg. Another lady we have seen was of 32 years, and 80 years lady also was operated with the same technique. So the results are remarkable unless the planning is done properly, proper alignment is done. If the measurement and proper alignment is done perfect, and it's a procedure of choice in young patients with medial compartment osteoarthritis. This is what is our message. And Dr. Kenty Zolokia, who said that although HTO has become secondary to uni in the Western world, but it will remain in this part of the world. And I'm thankful to Dr. Kosino for giving me a lot of encouragement for this technique. Thank you.
Thank you, Dr. Maheshwari. Now we move on to the next presentation. That's by Dr. Dinesh Thakkar from Ahmedabad.
Good evening, everybody. Can you listen me, sir?
Yes.
Okay. Now I will start sharing screen. Is it visible, sir?
Yes. You can do the full screen.
Good evening, everybody, and I am very thankful to Indian Orthopedic Association for giving me the opportunity to explain about the closed wedge high tibial osteotomy, infratuberosity. But it's not exactly infratuberosity, but it is at the level of tibial tuberosity. As we know, proper planning prevents poor performance. If we fail to plan, we plan to fail. So proper planning is extremely important in particularly high tibial osteotomy. Either it may be the open wedge or it can be a closed wedge. As Dr. Rastogi has already mentioned about the preoperative planning, but still I will explain in a few slides only. Commonly we are following the method Piniaki, which is the most perfect method, in which first we draw a mechanical line that is centered from femoral head to the center of the ankle joint, and then we draw a second line that, or line 1, what we call it, is represents the planned weight bearing line for the post-operative correction, and extending from the center of the hip through a coordinate of 60 to 72% of tibial plateau width. Either we can say it as a Fujisawa point also, and line 2, which we draw from osteotomy hinge point, that is on the medial side of the proximal tibia in case of closed wedge high tibial osteotomy, to the center of the ankle joint, and another line 3 that connects the osteotomy hinge point with the arc of intersection of line 1, and the angle formed between these two lines is our correction angle. That is what we call it as alpha angle. And then after measuring this alpha angle, we remove the wedge. We put a first cut at the level of tibial tubercle, just below the attachment of patellar tendon like this, and then another cut what we put at alpha angle, and then we remove the wedge like this, and then we close the osteotomy site like this after fibular osteotomy, and we can here see that the weight bearing axis has been now passing through the desired level. That is what we call it as a Fujisawa point. Now, as I already told you, the site of osteotomy is not exactly the infratuberosity, but it is at the level of tibial tuberosity, just below the attachment of patellar tendon, and it is an oblique osteotomy with a base in the diaphysis of the lateral cortex. Here we can see base is in the diaphysis here, and apex is in the metaphysis. So we try to bring the apex as high as possible. So we have a broad surface area in contact after high tibial osteotomy. So I would say it is a diaphysial metaphysial osteotomy. It's not a diaphysial osteotomy. So this is how what we can see here at the level of tibial tuberosity, apex in the metaphysis. This is how it is. It has been removed and closed like this. And here we should take care that the apex should be exactly at the medial border of the tibia. So it should not be away from the medial border, or it should not be lateral to the medial border. So this is very important for desired correction after high tibial osteotomy. So certain equipments is required. Nowadays, we are fixing always, we are not giving plasters. So first of all, this is the wedges prepared of every degree. I have a wedges starting from 6 degree to 30 degree. So whatever the correction what we want to achieve, we should have a wedge like this. And another thing, this plate Tomofix, what we call, and now it is available in India, by Indian company also, and we will require this patella holding clamp to hold the osteotomy properly. So the method in which we don't remove the whole posterior cortex. Here we can see that this wedge has been removed, but we keep the posterior cortex intact. We cut the posterior cortex only at the distal osteotomy, distal cut of the osteotomy. So we can slide the distal fragment over the proximal fragment, and this spike will support the, will stabilize, will give more stability to the osteotomy site. Not only that, we also preserve the lateral cortex with his vascular attachment. This lateral cortex we preserve with their soft tissue attachment, and then we remove only this part of the osteotomy, and this will be remain vascular. This will work as a vascular bone graft, and then after that we will close it and then fix it with the plate and screws. Now this 47-year-old lady has a medial compartment osteoarthritis knee, and there was no fixed flexion deformity. There was no ligament laxity. So, so in this particular case, there is a difference in if we are planning. At least I am planning on a non-weight bearing full length X-ray. I don't plan on the weight bearing full length X-ray because there is always some difference in angle in a weight bearing full length X-ray and non-weight bearing full length X-ray. If we see here if we plan, this is the weight bearing. Sorry, this has been written wrongly. This is weight bearing X-ray, and this is non-weight bearing X-ray. There is a difference. This is a mistake here. It's a non-weight bearing which shows varus of 7 degree, and this is the weight bearing X-ray, and that shows varus of 10 degree. This X-ray is of same patient, weight bearing and non-weight bearing. So there is a difference of 3 degree in a weight bearing and non-weight bearing full length X-ray. So if we are planning a closed wedge, particularly at the level of tibial tubercle, we are doing all planning in the non-weight bearing full length X-ray. Why? Because if I do planning in the weight bearing X-ray, I will get overcorrection of 3 degree, and it's a game of only few degrees. So if we do always in the weight bearing X-ray, then it may end up with the overcorrection. So this is how we are doing planning in the non-weight bearing full length X-ray, and according to Miniaki method, in particularly in this method, in this particular patient, we have to remove the wedge of 12 degree. This will be the apex and hinge of the osteotomy site, and we have to remove 12 degree of wedge from particularly for this patient. And another thing, what I am doing, I am planning to measure intraoperatively. So my aim is to bring the weight bearing axis from this point. So the long axis of TB after surgery of high tibial osteotomy, it should come in this direction. This should be the long axis of tibia. So I usually take intraoperative X-ray, and then I measure the intraoperative angle, not MPTA, not medial proximal tibial angle, but I measure the angle between distal femoral line. This is the distal femoral line. This is the distal femoral line, and this is the long axis of tibia. So particularly in this patient, this is our target is to achieve this angle 94 degree. So to achieve exact 94 degree is very difficult. So we keep some range. It's a game of only few degrees. So our aim is to achieve the angle between 92 to 95, right? So we have a targeted 94 degree, but we can accept up to 92 to 95. And so this is our planned post-operative long axis of tibia. This is the planned post-operative long axis of tibia after surgery. So now how we can measure, how we can check during surgery, because I don't rely on quadripod test, because quadripod test is not a reliable method, because it may mislead many times. So we made a template like this. This represents the long axis of femur, and this represents that 80 MPTA 87 degree, this long axis of tibia. This is normal. And then we have drawn another line, which is green line. What we can see is, and this is 92 degree. So our tibia should be minimum during surgery in a post-operative X-ray. Long axis of tibia should be at least on this line. So this is our plan. Sorry, my internet connection probably may not be perfect. And another line that is 97 degree. So we have targeted our long axis of tibia on 92 degree. Sorry. Now I will show the operative method, how we do the surgery. Can everybody hear me?
Yes.
Okay, this is the incision, midline incision is being put. Proximal tibia is being exposed. And then periosteum is elevated from the area where the wedge is to be removed. So this is the periosteum I am erasing from the proximal tibia, from where we have to remove the wedge. And then I fix, this must be 12 degree or whatever the required wedge is to be removed. Here we can see that apex is exactly on the medial border of the tibia. And then I fix it with 2 K wires on the proximal tibia. This is the proximal cut of the osteotomy. And this is the distal cut of the osteotomy. This is, and here in sets we can see that this is how the wedge is to be removed. This is after that I separate the lateral cortex. Still I have not detached the soft tissue attachment of the lateral cortex. After doing multiple hole in the lateral cortex by K wire, I separate it out with its vascular attachment like this. Here we can see this piece has been separated, and then wedge is to removed like this. And then one screw is passed in the proximal fragment with SS wire, and another is in the distal fragment. Previously, I was doing it is at the parallel of the osteotomy, but now I am passing this screw juxta-articular. This is the distal screw is being passed, and then after doing this, still I have not cut the posterior cortex. Posterior cortex is still intact, and then I osteotomize the segment of the fibula like this, and then I cut the only distal cortex of the osteotomy. I keep the proximal posterior cortex intact, and then I slide the distal tibia over the proximal posterior cortex. And then after closing the osteotomy, I hold this with this clamp, pointed clamp. I hold osteotomies like this, and then I tighten the stainless steel wire between one proximal and one distal screw on the lateral cortex. This is how the SS wire is being tightened. Now it will become a very stable osteotomy after tightening this stainless steel wire. And then I fix on the medial side with the medial locking plate. Any plate we can use, but usually I am using Tomofix because it is an angle stable implant and very strong implant. And then first I pass the cortical screw in the distal fragment. And after that, one cortical screw with a proximal fragment if I get a space. Otherwise, sometimes I cannot get the space on the proximal fragment to pass a cortical screw. So I have to pass only 3 locking screw in the proximal fragment. This is how we fix it with the proximal, and then distal screw is also being fixed. Remaining SS wire is also being cut, and this is after closure of the osteotomy. This is how we are doing closed wedge high tibial osteotomy. Now, during surgery, we take per operative X-ray like this after tension band wiring, and this clamp is being pulled. And this per operative X-ray, I put it on this template like this, and then I measure and whether I have achieved the desired correction or not. Here we can see that the long axis of tibia is exactly here in the green line. That is 92 degree, what we have calculated before surgery. And this is how, if we are satisfied that we have achieved the adequate correction, then and then we do remaining fixation, right? So this is the method to avoid the under correction. So if we see on a model, then we can see here that the wedge is removed like this. This cortex is kept intact with this soft tissue attachment, and only this proximal posterior cortex is not cut, only distal posterior cortex is being cut, and this is how it has been closed. And here during surgery we hold like this. One point we keep here, and second point of the patella holding forceps we keep like this, and plate. After that we put a plate and fix it with the screw. And this is the final picture of the fixation. Here we can see this blue dynaplast represents as a soft tissue attachment of this fragment, and this is the screw, and this is the tension band wire on this side, and this is the strong plate on the medial side. So it becomes stable from everywhere. On lateral cortex, it is vascularized bone graft with this tension band wiring. On medial side, it is strong Tomofix with their locking screws. And in posterior aspect, we can see here the strong posterior cortex is supporting the osteotomy like this here. And so it becomes stable from all the 3 surfaces. So it becomes very stable. So we can allow them to do a partial weight bearing from the next day. Here, if we see the post-operative angle of this by all method, we can see this is full length. On full length X-ray weight bearing line is passing from the Fujisawa point. And if we measure mechanical, there is a valgus of 4 degree. That is what our desire, our target is 3 to 6 degree of mechanical valgus. And there should be 10 degree of femorotibial angle. That is long axis of femur and long axis of tibia. The angle between these two is 10 degree. So this is anatomical valgus. And MPTA is here 99 degree. So after surgery, this is the preoperative clinical picture. And on second post-op day, we allow patient to bear weight, partial weight bearing like this. And they can go for the toilet purpose and they become mobile on the next day. So this is the advantage of that they are mobilized quickly after surgery. So, now if patients are young and have normal BMI or not more BMI, then we do both the on both sides we do high tibial osteotomy and a single stage. Here is a 49-year-old female with pain in her both knees since long, and then scanogram was taken, and it was planned to do bilateral high tibial osteotomy in a single stage. And here, after surgery, the weight-bearing axis very well passed near the Fujisawa point. This is the clinical picture, and this is the lateral view. And we allow her to walk on the fourth post-operative. This is the fourth post-operative day. This is she was encouraged to walk, but not much. That is very restricted walking on the fourth post-operative day, even after doing bilateral high tibial osteotomy and a single stage. So, but we don't do after age of 55 years, and also we don't do it with a high BMI, even with a younger patient, even in young patients. Then we advise them to do one after the one and second after 6 months. So this is the clinical final picture, preoperative and postoperative after bilateral high tibial osteotomy. So there are limitations of open wedge, not only open wedge, but even supratuberosity closed wedge. Varus more than 12 degree may not be possible, probably by coventry osteotomy. Flexor deformity more than 10 degree probably becomes difficult with a supratuberosity or open wedge. And valgus lateral compartment osteoarthritis with lateral valgus knee, probably open wedge, lateral open wedge has not been described. And here we can see that varus more than here 12 degree, but here on one side it is 26 degree and on another side it is 18 degree. This is the clinical picture of this before surgery, and after HTO we can see here that is very well corrected, and in post-operative X-ray also we can appreciate that the correction has been achieved as we desired. And after surgery we can see that how she was walking before surgery, and after bilateral high tibial osteotomy, the gait has been improved and she can walk very comfortably. So here flexion deformity more than 10 degree, here we can see that about 20 to 20 degree, more than 20 degree of flexion deformity. That flexion deformity has been corrected very well, and varus also has been corrected very well. And this is the preoperative and postoperative clinic X-ray picture. Here we can see that weight-bearing axis is very well corrected. Flexion deformity was corrected by alteration of posterior tibial slope. So slope was reversed, and in that way we have corrected FFD by removing the base, anterior more base and posterior less base, and in that way we have corrected the flexion deformity. And how she was walking before surgery and after surgery of bilateral on both sides, we can see that now she is walking comfortably. So this is how the advantage of doing high tibial osteotomy at little lower level, at the level of tibial tuberosity. We can correct flexion deformity also, we can correct more varus also, and we can do even medial closed wedge in lateral compartment arthritis. Here is a lateral compartment arthritis. We can see valgus knee here. After surgery, the limb has been straightened. Patient can do Vajrasan, can even do Padmasan, and can squat also. And this was a clear X-ray picture. Before, this is lateral compartment arthritis. Weight-bearing axis has been corrected to the center of the knee joint, and he was doing able to full function. Another thing is internal tibial torsion is also possible to correct during closed wedge high tibial osteotomy. We can always rotate the distal fragment to bring the patella in center, internal tibial torsion in a normal torsion. Here we can see that there is a tibia is internal tibial torsion. Patella is like this. After surgery, we can see that patella is, and this limb is the rotation, internal tibial torsion was corrected. So this is the dynamic varus. We can see that while she was bearing weight, the varus was increasing. So if we look the X-ray, then on weight-bearing X-ray was like this. There was a lot of opening on the lateral joint space. And if we take a non-weight-bearing X-ray, then it was like this. So we always calculate a non-weight bearing X-ray, and after surgery, it was corrected very nicely near the Fujisawa point. And that was after 6 months. This was weight bearing X-ray. Now this happening was not after this correction. And if we see after surgery that this dynamic varus has been corrected, now post-operatively we can see that there is no opening of lateral joint space. So if we do proper high tibial osteotomy, even varus more than 15 degree and dynamic varus, all these things can be corrected. Here we can see that there is a lateral thrust. On the left side, we can see tibia, proximal tibia migrates laterally on weight bearing. This is a lateral tibial thrust on weight bearing. On left side, we can appreciate that. And if we examine her clinically, there was a, if we examine her clinically, there was a laxity of lateral collateral ligament. Not only laxity of lateral collateral ligament, medial collateral ligament was good. And this is the how, and then there was a laxity of anterior cruciate ligament also. See, there was a laxity of anterior cruciate ligament also. So there was 2 ligament laxity that leads to lateral tibial thrust. And after surgery, we can see that lateral tibial thrust has been gone after correction of varus. And in this particular case, varus was also corrected and posterior tibial slope was also corrected. If we see the post-operative X-ray, pre-operative and post-operative X-ray is like this. And after doing both, she can able to sit cross-legged. So here, this posterior tibial slope was also corrected. Not only varus was corrected, here there was too much of posterior tibial slope. It was bring to the normal. So it's not out of complication. So the complication is always there, not always, but there is also few complications which we can face in. This is the excessive valgus, what I have faced in my practice, and this is the non-union.
Dr. Thakkar, you have lost connection. Dr. Thakkar, you have to unmute. Dr. Thakkar, you are not audible.
Okay. Now you should be audible now. Hello.
Yes, now you are audible.
I think my presentation is already completed,
Right.
but still. Thanks for your kind attention. Thank you, sir.
Right. So, Dr. Thakkar, I would like to ask one question.
Yes, sir.
When you are doing osteotomy for a closed wedge and the posterior cortex is intact, and you have taken away the wedge, and when you push the distal fragment into the proximal fragment,
Yes, sir.
so the slope is already unstable. Unstable means till you fix it, you can change it.
Yeah, it's possible. There is always possibility, but most of the patients have little bit of flexion deformity also, many 5 degree or 10 degree. But still, if I want to maintain the slope, I can maintain it with experience, of course. And if I want to reduce the slope, I can reduce it. And if I want to increase the slope, I can increase it also by removing the wedge on the posterior aspect. If we keep the parallel limb, it remains as the same posterior tibial slope. If we cut more posterior cortex and less anterior cortex, we can increase the posterior slope. And on the reverse side, if we remove the anterior wedge more and less posterior cortex less, then it will reduce the posterior tibial slope.
Now, the question I want to clarify is, when you are fixing the osteotomy side, then one will have to keep the C-arm in the lateral position all the time to see that the slope is corrected the way we want it to be correct.
Not that, but what I usually do is while cutting the proximal cut and distal cut, I put thinner blade inside, and I see whether I have cut it parallel on the lateral cortex or it's converging or diverging. So still I can adjust accordingly. And then while closing the wedge, I tighten it with the tension band wire on the lateral side, and I have to check whether posterior cortex has been closed or not. Right? If it is closed very well, then posterior slope will not change. But if it remain open little bit on the posterior side, then it will reduce the posterior slope. So suppose I want to increase, that is very difficult in closed wedge to increase the posterior tibial slope, but still few degree, 2-3 degree, we can increase the posterior tibial slope. How? We can cut the anterior cortex less and we can cut the posterior cortex more. And then after closing, I check it that whether it has been closed very nicely or not. If it's very closed very nicely, then we can increase the posterior tibial slope. Very little, not much. Open wedge can increase the posterior slope very nicely, but closed wedge cannot increase the posterior tibial slope as good as open wedge. But still, most of the time, I can manage to maintain the posterior tibial slope if I want. But most of the time, what happens, there is a 5 degree or 10 degree of fixed FFD, and we need some hyperextension while walking. 5 or 10 degree of hyperextension normally we should have on standing, because we should lock the knee. So that if I reduce the posterior tibial slope in many patients, then it helps to the patient, not damage to the patient.
Dr. Mangal, how would you comment on the having a hyperextension for locking the knee?
Out of the two, I think mild hyperextension, a few degrees of hyperextension is better than flexion deformity. So if you have to make a mistake, a few degrees of hyperextension is probably better. Dinesh and I always argue with each other in terms of correcting flexion deformity by changing the slope. He does it beyond 90. I don't advocate that, but he says he has not had any problem with that. So, but that is one area where we agree to disagree, sort of, in terms of correcting the flexion deformity.
Dr. Maheshwari, the plate which you have had made, is it side specific or is the same plate?
No, we have got different degrees of plate, 10 and 15. Depends on the wedge size we remove. We use the plate.
Anyway, what he wants to ask, that it is right or left side both same or different?
They are same. They are same.
They are same.
Yeah.
But since it's a close wedge, how does the angle makes the difference?
Sir, I'm sorry. I didn't understand the question. We have got right and left separate.
Right.
Yeah, we have got right and separate.
Mm-hmm.
The question, yes, it is right is different and the left is different, and the angles are again different for the different wedge removed.
Okay.
Are there some questions from the audience.
So my question to Dr. Maheshwari is how much maximum wage you can remove?
Sir, we have, I have shown in the one of the video, which I shown that the wedge was of 2 centimeter. So if we roughly calculate 1 degree is equal to 1 millimeter, 20 degree of deformity has been addressed, and 2 centimeter is routinely we are able to remove without any issue. That is because we have enough space. There is enough space from tibial tubercle to above. Sometimes we have to compromise with the size of the proximal 2 centimeter. Instead of 2 centimeter, we may get little less, but still it is feasible to fix the plate or whatever implant we want. So 20 millimeter of wedge is commonly we can remove easily without any problem.
And another thing, what I wanted to ask, the commonest complication which was with the Coventry, but nowadays you are fixing it with the locking pin. So loss of correction, because with staple and plaster, we have seen many patients in our residency that when what we have achieved the correction was lost during the process of union in plaster. So what is your experience about this?
I agree with you on this point. In the initial, when I started the Coventry using Coventry staple, sometimes because the union was delayed and because of that the stability was not maintained with the plaster, or the in between the plaster was sometimes getting broken, and in those cases we were losing our stability and the angle wanted. But thereafter, I started using the bone graft. I used the chips in between and snugly fitting bone graft along with the plasters, and now we got a synthetic material. So thereafter, I didn't come across any problem like that where I lost the correction angle what I wanted.
Dr. Maheshwari, for closing the wedge, like Dr. Thakkar has used a tension band wire to stabilize and close it. Do you think there is a need to do something when you are doing a closed wedge supratuberosity?
Sir, I have seen, I told in the beginning of my lecture that I have observed doctors Junjunwala.
Yes.
In Home Hospital. He was, and Dr. Sancheti as well. They were putting 2 screws, 1 screw above and 1 screw below the osteotomy. And they were closing with the tension band wires, and then they are supporting it with the external plaster. I have seen them, but in my practice, I have not used it.
No, I was asking on table before you apply the plate.
It is not.
Or the pointed reduction forceps is enough.
It is not required because I got enough. When I put the proximal screws, then when I close it, I just ask my assistant to push more. That's it.
Right.
And then I lock it with the screw. So thereafter, it is so stable, it doesn't move at all. And while putting the staple, it is simultaneously fixation.
Right.
So my assistant is holding nicely, and then I'm comfortable now. Everything is stable. Then I push the staple, so it goes simultaneously in proximal and distal both. So there was hardly any problem thereafter.
So what is your post-operative protocol?
Post-op protocol of my plates.
Patients, suppose you have operated on today, when you will make him stand, make him weight bearing,
With my
knee bending.
Yeah. With my this new plates I'm using now, patient is mobile on the next day. We allow them non-weight bearing, crutch walk, and after 15 days we allow them partial weight bearing, and after a month they can put the weight complete. This is what is my weight bearing protocol in the patient. Knee bending we start on the next day. Initially, we ask them to district up to 90 degree, and then gradually we allow them to go for full knee bending. But by the time patient is discharged from the hospital, we keep the patient for 2 days in the hospital, And before the patient goes home, it is just, we reach up to 90° on cot. Patient is sitting on the edge of the cot before it goes home. So we ask them not to go further because it is possible, but then we say that it is not necessary. You can gradually increase your knee bending. And we hardly come across any patient who has got knee stiffness post-operative or thereafter. We have not come across any knee stiffness.
Even with the plasters.
Even with the plaster, because see, basically when we don't open the joint, the structure inside maintained so nicely that it takes little more time. With the plaster, it will take little more time, but stiffness will never persist thereafter. It will take little more exercises. But knee stiffness was not seen. That is what we usually see in the hemarthrosis. We give plaster and internal support for 3 weeks to 4 weeks. We don't see stiffness. That's the same thing here because we don't open the joint.
Now,
Yes.
this is for both of you. If a unilateral close wedge has been done, do you think shoe rays are needed or they are able to manage without it if it's a unilateral case?
Sir,
Your friend Dr. Maheshwari first.
Sir, can you clear it? What exactly is the question?
The question is, when you do a close wedge osteotomy,
Yeah.
is there any limb length discrepancy?
No, sir. Limb length discrepancy is a very good question. Yes, that was what we were discussing about. That because we are removing the wedge, we are removing some bone.
Right.
While doing valgus, it has to be lengthened. But since we are not lengthening, or we are not putting inside, we are removing it. So whatever we remove is almost compensated in making from varus to valgus. So we have not come across anything which is limb length discrepancy issue. Yes.
In varus osteotomy, we face some shortening. If we do varus osteotomy in a valgus knee, so there is some shortening, what you say. But in lateral close wedge in a varus knee, if we do valgus, the limb length remains same. Because I have done a few open wedge osteotomy also. In open wedge, there was always some lengthening, what I have seen in my patients. So
Because
limb length.
it is from varus to valgus as well as we are opening.
That is.
So has to go for a little lengthening.
Opening means you are opening from varus to valgus. That's the opening you're saying. The osteotomy is closed.
Yeah.
No, our osteotomy is closed, so limb length remains same. But in open wedge, it opens, and varus to valgus, both the things goes in favor of lengthening. So there is a little lengthening in open wedge. You must have seen in your patients also, but it's not that much remarkable. So it does not have any influence on the outcome of the patient.
Dr. Parihar will comment on that.
No, I agree with, I think, what you are saying, that with the straightening, there is length gained and you are subtracting length. And the question would hold true for either. I mean, even if you're doing a unilateral opening wedge, then do you give a raise on the opposite side? Up to 1 centimeter of limb length discrepancy has no clinical consequence. Nobody, even the patient, does not come to know about it. So personally, I don't think, unless it's a gross, the bowing kind of O kind of deformity, then yes. But for the run-of-the-mill OA knee with varus, I don't think any shoe raise is required personally. What is your experience, Sanjay?
I did for the time being, when you are doing in a unilateral case, sometimes some patients want a shoe raise, but when you do it in a bilateral, it's more patient dependent rather than the.
How do you decide how much raise to give?
Either by the block measurements, you make a guess, and then the patient decide what fits him best.
Yeah, so that's my point. That patient who have been walking with a slightly shorter limb or a longer limb, when they have a straighter one, then they feel it longer or shorter. But when you do a full length X-ray, you will find that there is no significant difference. So I usually will tell them, just keep walking like this and you should get used to it.
Right. So, Dr. Mangal, would like to make some more comment on the.
No, I want to know one more thing from all three of you all. How many of you all, I mean, how many of your patients do you do full length X-rays 1 year, 2 years later?
Always in all follow-ups after 6 weeks, 6 months and 1 year.
Full length X-ray.
Yes,
So 1 year and then 2 years again. You do
yes,
that?
yes. Or
What
like-
do you find in terms of your angle of correction? Is it maintained or is it changes?
No,
I find that it changes.
it changes, sir. It changes because what happens to me that when I always take full length X-ray before discharging the patient. That is whatever the correction I have achieved. If I take it when patient comes to do HTO on opposite side, it may be after 6 months, 1 year, 2 years. Many times it may be 5 years also. So even at that time, I take the full length X-ray both lower limb, one which is operated before few years and one which is to be operated. So I compare immediate post-op and then follow-up X-ray. Either it may be average 2 to 3 years. Then the valgus has been increased because internal fixation with plate is on. So it gradually, how it increases, I don't know. That was the question in my mind also. Why it should have increased the valgus? I don't know. But it increases the valgus. Because plate is inside. So I don't remove the plate. I don't suggest to remove the plate unless it creates some problem. What is your experience? Because you
Maheshwari?
are,
Yes, sir. My observation is, my two observations. First observation is that once we have done correction from varus to valgus, certain patients do get pes anserinus bursitis or tenderness. They have got more tenderness on the medial side, not on the joint line, but just below that, the pes anserinus, because it is stretched. And this was happening less with the staple and the plaster. But with the plate, when I do correction, say 3 out of 10, they come with in the initial period, they come with the pes anserinus tendinitis. And I may have to inject sometimes with the local steroids. And second observation is this ligament stretch, which has been done with the correction. They get gradually stretch more medial side, medially gets more stretch, and it opens up. The medial joint line gets more, opens up, and it goes little into valgus, as Dinesh said. So the valgus angle increases and varus angles reduces and it just opened up. This is the observation.
Sanjay, what do you find?
with the tomofix, I don't find any change in correction.
what is your observation, sir?
No, it changes. It changes. There are times when I think in the large majority, whatever I have at about a year remains so. But there are patients where I will be surprised by the reduction in the space. Not reduction in the space, reduction in the angle. I have not kind of studied that in detail, but I would estimate that it's about 20% of the patients who have a little reduction in the angle. Clinically, they are all fine.
So reduction means if the which angle will reduce when you're doing a.
We are looking at the HKA basically.
Right.
So, and the other thing I've learned is that positioning makes a big difference in the X-rays. So therefore, if and I do the positioning with a lot of care and all that. And despite that, we are getting some changes. So, and if you look at the literature, there is no literature which has looked at what is the accuracy of correction. Meaning, all of us show these x-rays, patient is doing well, patient is fantastic, patient is sitting cross-legged, patient is climbing the Alps, patient is running this, running that. But nobody shows, I planned for 183 degrees and I achieved 184 degrees, or I achieved 183 degrees. This is something I think that needs to be addressed, because if we are claiming that angle is important, then what was planned and what was achieved, and I think it should probably be a X-ray 3 months to 6 months later, because that's when the patient is actually properly weight bearing. You know, when we do, I also do like Dinesh, if I've done an acute correction, I will do it when the patient is discharged, or if I've done it with a fixator, I will do it when the patient comes for locking. But that may not be a full weight bearing, despite the fact that we tell the patient to take full weight on the leg. They may not be bearing full weight for various reasons. So this exemplifies the saying that the more you know, the more you realize how little you know.
Yeah,
I have no answers to why it happens. I observe that yes, it happens, but no clear answers onto why it happens.
that is also, if we take a full length X-ray of the same patient in a different time, in a same position, we try to keep it as the same position. Then also there is a difference of 2-3 degrees. I don't know why.
So I have patients who say I have advised them surgery a year ago.
Yeah.
And they have now come. And I will then, before surgery, I will do an X-ray again. So it's not only post-op, even the pre-op. That's why I said, no, the positioning makes a difference. So earlier I may have found that, okay, the LDFA was 85, 89, but now it seems to be 91. And so then I will add a DFO for them. So there are some of these things are still gray areas, and we are flying up by the seat of our pants, so to speak. We have reasonable theory and a reasonable rationale, but also at the same time, there are the outliers also, where we are not sure what is exactly happening. Those patients are doing well. No question about that. Clinically, if you see them, they have no complaints. But their angles are different.
So we are coming to the close, and if there are no questions, I would like to thank the speakers for their.
Sir, excuse me.
Yes.
Once we have Dr. Mangal Parihar with us, I want to ask a question to him. Now, recently I started, it's about a close wedge of tibia, but close wedge of distal femur. So in last 2 DFO, distal femoral osteotomy, either varus osteotomy or valgus osteotomy, I started to fix it with on both sides. So what is your comment? Because I want to allow the weight bearing very early. So is there any disadvantage, or is there any comment from you? If we fix it on the both
I will put a reverse question. What is the advantage?
Advantage
I
is
take a lot of care to ensure that the first few cases which I have done, I have had a breakage of the hinge in some of the cases. Now, I don't have a breakage of the hinge. So that medial side is pretty much intact, and there is a very, I think I put up a video, if you remember, on the knee preservation group. So that remains intact, and it's biplanar. So to me, that is pretty stable. And with that kind of osteotomy, I can allow them weight bearing, but in my case, I don't allow them because they have the fixator on for the HTO. But I don't think there should be a problem with just because essentially you're closing the book and holding it closed. If you've got a stable situation, there's no real reason to put a implant on the medial side. It's just more surgery, more incisions, more areas of pain, etc. But have you had any trouble with just using a lateral implant?
Lateral implant, not since few years, but previously when I was fixing it with only in the lateral side in tibia, on weight bearing, there was some loss of correction. That was I was facing in tibia. So hypothetically, I think it for the femur also. If I
No, I think in the femur, the other thing is the place where we keep the hinge just above the condyles. There's a lot of soft tissue attachments over there. And there are papers from Japan also in the literature, if you see, that when the hinge is there versus elsewhere, if it's higher up, then when the hinge is at that particular point, they've demarcated that point. The chance of displacement of that hinge is very, very minimal because of the very strong soft tissues. Even when you're doing the osteotomy, when you try to raise the periosteum and you're reaching towards the condyle, it's very difficult to raise the tissues over there on the posterior aspect. So in that sense, I think the femur is different from the tibia, and the risk of displacement, etc., is minimal.
And would there be a need to use a compression device for a closed resin femur?
No, there is in the steps after you fixed it distally, you put an oblique screw,
Right.
you know, the golden screw, the cortical screw, and then pull that
That is good enough.
towards you. That is good enough.
Right. So if there are no questions, I think we'll come to an end. And before I thank all the speakers, I would just like to tell that we have done the basic knee preservation on air. Then we did a face-to-face in Kanpur on the modern techniques. Then we had one topic, one speaker on 10th June. And today this is the next webinar. And now we'll have techniques of medial open wedge, high tibial osteotomy. And I'm in touch with Dr. Mangal to decide the date. Then Dr. Milind will speak on TCBO in August. Then we have a face-to-face in modern techniques in Gujarat. Dr. Thakkar would help us do that. Then we'll plan a webinar on TCBO and DFO. And then Milind is doing a face-to-face probably from 1st to 3rd December. And then we have pre-conference workshops. In the meantime, if you find anybody who wants to have lectures or workshops or bone demonstrations, then we'll be more than happy to help them do that. So with this brief, I thank Dr. Mangal, Dr. Maheshwari, and Dr. Thakkar for their help, like always.
Thank you, sir. Thank
Right.
you.
Now we
Thank
close the session.
Thank you.
Good night.
Bye-bye.
Bye-bye.
Good night.
Good night, sir.
Particularly minute near the group. Kamu na tum? Ele minute